Good afternoon, or morning for some. I'm Dr. Edith Mitchell from the Sidney Kimmel Cancer Center at Thomas Jefferson University in Philadelphia. And I am so pleased to be here with you today. And thank you for being here. I will talk about the nurse's role in early stage breast cancer, a focus on genomic assays. This is so important now as we build teams and as we learn more information about genomic assays. It's so important for us to understand how we can all play a role in patient management, because that is what it's all about, the patient. My disclosures, my objectives, and we'll move forward. In 2011, when the St. Gallen consensus recommendations were published, and it became very useful for us to move forward past just the hormonal assays of breast cancer management, and certainly notice that the subtypes of breast cancer were published with recommendations on the management of breast cancer based on the subtype. And with immunohistochemistry, we were able to subtype breast cancer tumors based on other pathology, and that gave us the luminal A, luminal B, and luminal B based on two separate assays. The next was the HER2 positive patient's tumors, and the last and the most aggressive and most challenging, the triple negative breast cancer subtype. So why do we say breast cancer subtype triple negative is such a challenge? Well, for first place, it is more commonly seen in African American patients. There is a higher mortality rate and frequently advanced stage distribution, but some of the patients may present with actually a very small tumor. Still, it's challenging to manage. Until recently, African American patients had a lower lifetime incidence. That gap, however, has been closed. African American patients present with a younger age distribution, that is development of tests at a development of cancers at a younger age. There's increased frequency of adverse tumor features, and also a higher incidence of male breast cancer. And all of these features of the disease may be affected by number of factors such as socioeconomic disparities, delivery of care, which we'll talk about later, the tumor biology, genetics, lifestyle and reproductive experiences, and environmental exposures, as well as diet and nutrition. For breast cancer stage distribution by the receptor status and race, very important to evaluate data. And these data were taken from the surveillance epidemiology and end results database. And what that showed was that white patients are more likely to have hormone receptor positive disease and HER2 negative. And if we look at the comparison of white patients to Black patients, note that white patients have a higher incidence of this subtype of breast cancer. For triple negative breast cancer, while it is lower in incidence, approximately 21 to 22% in the United States. Triple negative breast cancer is more commonly seen in African American patients. A lower number of individuals will have hormone receptor positive disease and HER2 positive, and the races being approximately equal. And then for her, hormone receptor negative and HER2 positive, small number of patients, but African Americans are more likely to be seen with this type of receptor status. And regarding screening, what we find is that with the evidence for race and ethnicity and triple negative disease, note that patients present earlier in life and usually and frequently below age 40. And these are the other age groups. And what we know is that African American patients, whether they are younger than 40 or older than 75, they're more likely to have triple negative breast cancer. So it's so important for the clinicians and all clinicians to recognize these differences and make sure we evaluate patients accordingly. So why do we say African Americans and the burden of breast cancer in this racial or ethnic population? We know that from data from many sources, African American women are more than 40% are more likely to die of breast cancer than white women, more likely to be diagnosed at a younger age, diagnosed at later stages of the disease, and diagnosed at later stages of what could initially be seen as early breast cancer, but with further diagnosis and use of diagnostic tests, we may find that there's actually a later stage of disease than initially anticipated. African American women are more likely to show that there are more aggressive forms of the disease, and there is a lower 5-year survival rate when compared to white women. So therefore, it's very important for us to understand racial and ethnic potential differences in our patients presenting initially with breast cancer. So let's talk about some of the assays that we have that we can utilize in assessing patients and their status when they present. The most commonly used test in the United States is that of Oncotype DX recurrent score. This is a 21 gene panel that is PCR based and very useful. Based on the levels of gene expression of 16 cancer related genes and 5 genes for expression normalization, this test can use fixed paraffin embedded tissues, so it can be obtained later as long as there is paraffin embedded tissues. Our recurrent score is given with numbers from 0 to 100, and that translates into 3 risk group categories. Low, with a recurrent score of less than 18, intermediate 18 to 31, and high greater than or equal to 31. And a report is given with this information that we can utilize in addition to hormone receptors and HER2 that are initially given for the tumor. There is also the MammaPrint, and the MammaPrint is a microarray based gene expression profiling assay. It utilizes proliferating genes and genes associated with invasion and angiogenesis. It will provide an independent view and prognostic information beyond the standard clinical pathologic variables. It is the first FDA approved gene expression based assay to be used as a prognostic test for women with node negative breast cancers. It is based on microarray results, and very important for us to realize that this requires high quality RNA from freshly collected tissues. So the MammaPrint uses freshly collected tissues. There is another that is not so frequently utilized, but I want us to discuss it today, and that is the MapQuant-Dx genomic grade. This is a predictor test derived by identifying 97 differentially expressed genes from grade 1 and 3 breast tumors. Most of the genes in this signature are ones that are involved with cell cycle regulation and therefore tissue and cancer proliferation. It gives a genomic grade index, or GGI, and GGI is strongly associated with the risk of recurrence among patients with grade 2 tumors. It is microarray based and therefore, again, requires freshly prepared tissues and high quality RNA specimen. There is also the Breast Cancer Index, or BCI. This is also a prognostic array that provides assessment of the likelihood of distant recurrence in patients diagnosed with ER positive and node negative breast cancer. The BCI stratified about 50% of tamoxifen treated patients whose tumors were ER positive, node negative, and with breast cancer into a low risk group for 10-year distant recurrence. Again, very important. And the BCI was developed from the combination of two indices, a 2-gene ratio, and it predicts distant recurrence in patients with ER positive disease treated with tamoxifen. In addition, it has proliferation related 5-gene molecular grade index, and that discriminates grade 1 from grade 3 disease. It also can utilize paraffin-based embedded tissues. There is also the PAM50 assay. PAM50 assay provides a risk of relapse, or an ROR score. It is prognostic of relapse-free survival for patients, again, node negative tumors who did not receive adjuvant systemic therapy. So the ROR, together with this, with the tumor size, outperformed standard clinical pathologic variables, proliferation marker Ki67, which has been used for many years, combined with the progesterone receptor and histologic grade of the tumor. The ROR model proliferation component contained 11 of 50 PAM50 genes associated with cell cycle function, and it is compatible with, again, paraffin embedded tissues. So with these assays that we can utilize in addition to our usual clinical pathologic variables and tumor expression, therefore we can all come together as a team And I will now talk about some of the functions and role of the oncology nurse in the breast cancer management team. And I call it the breast cancer care team. There are many components with all of this information that is available. So, what can the nurses do as a part of this team? And the nurse's role has actually developed and progressed over several decades. So now there is really very much involvement since there are so many data points that we have to utilize in the management of patients. So first of all, patient assessment. What identifies each individual patient as being unique? There is development of the nursing care plan uh, and assessing the patient's needs. The nurses do such a great job of assessing uh, unique needs of each individual patient, some of which are related to socioeconomic factors, family affairs, and others. For example, whether the patient will work during treatment and has a career, or whether there are care of family needs, small children, or parents, or other needs that the patient has. Um, Important to find out how far does the patient live from the treatment site? What are the necessities of arriving at the site? Whether other family members will have to take off work or other needs if the patient is using public transportation to arrive at the site. And what are the out-of-pocket costs that the patient has that will allow freedom for participating in the treatment plan? We need to provide the patient an understanding of the diagnostic as well as the therapeutic goals, communicating the treatment schedules, discussing possible treatment side effects, educating on the potential of physical and psychological preparation for participating in a treatment plan, and then providing that much needed physical and psychological comfort to the patient, as well as indicating the need for each component of the treatment plan and discussing the required compliance and adherence to the treatment plan. There is also the patient education, as well as family or caretaker education, describing the disease and the treatment, explaining decision-making and options in the care plan. Also informing the patient of community and advocate resources and services that may be tremendously important in terms of healthcare delivery and out-of-pocket cost. We also, with the nursing area, describe highly predictable problems, oncologic emergencies that might potentially occur, and then some of the major side effects of the disease and or the treatment. And again, describing the schedule. Many patients have so much knowledge input that they may become confused on any of these aspects of the therapeutic care plan. So nurses becoming advocates for the patients, making sure that the patients have all the components of the treatment plan itemized and listed. There is also so important coordination of care. That is coordinating the direct care that is provided to the patient, as well as documentation so that others can understand that information that is given to the patient. Again, I'll mention symptom management and potential discussions of side effects. Help organize the referrals to other providers that the patient will need, and then making sure that the patient has the location and the dates of those appointments. Then there is the patient and family education support so that the patient has others that can confirm and work with the patient on the schedule and the participation in the schedule. So there's the patient and family education support as well. And then what I find is so important for the nurses to telephone, follow up with the patient in some communication avenue. Sometimes it could be phone or my chart or whatever method is used in the practice, helping the patient understand and then reconfirming the information that has been given. And then patient care, so important to make sure that the patient's weight and body surface area and other data are correct so that we can give the correct dose, the correct drug, and to the right patients so that we are administering therapy that is exact to the right patient at the right time, very important, as well as the right dose. Symptom management, I mentioned again, as well as other factors related to the individual patient, whether there is pain, and therefore pain management, and then survivorship once the patient has accomplished the appropriate therapeutic plan. So that is all important, and very important that we not only communicate all of those factors, but also letting the patient know about clinical trials and other components of care that might be appropriate and realistic. With all of that, we're now going into the future with newer assays and genomic profiling of tumor. There are multiple companies that provide genomic analysis of tumor, and I won't go into those specific ones, but there are multiple ones on the market. What I will emphasize is that the future of breast cancer management, as well as other tumors, is genomic analysis and looking to the future, guiding therapeutic plans based on the genomic analysis. The NCI, National Cancer Institute, has a study that is ongoing now on the molecular analysis of therapeutic choice, or it's called the MATCH study. It's a phase 2 study where genomic profiling allows for the choice of therapies and therefore based on the genomic analysis of the tumor. It's the objective is to determine whether matching certain drugs or drug combinations in adults whose tumors have specific gene abnormalities, and whether this will effectively treat their cancer regardless of the cancer type. So it's choosing therapy on the genomic analysis as opposed to the actual tumor analysis that we've been used to evaluating. And in the MATCH study, there are a total of 39 treatment arms. Some have been completed, others are ongoing, where we're evaluating 39 different treatment arms based on the genomic analysis of the tumor. Another area that I think has tremendous potential in the future, and that is related to the NIH All of Us research program, which has a goal of evaluating over 1 million individuals, one, to determine whether there are diseases that are at risk for an individual patient and how that information can be utilized. So it is anticipated that this will deliver the largest, richest biomedical data set ever, and whether individuals can use this information early on before disease is actually present. So it helps with factors that are related to inheritance and other environmental factors to help patients early before the development of disease. So this study is ongoing, and I do recommend it to my patients to consider this information or this study, and family members can also participate. This study, as I mentioned, is recruiting a group of 1 million or more people in the United States, and it is developing a national resource to allow for evaluation of specific diseases before an individual actually has any symptomatic evidence of the disease. So with that, at Jefferson, we have developed this program looking at the patient population, the individual patients, how we can combine community outreach and education, partnerships in communities that will allow patients to overcome certain barriers and provide community resources. It is combined with our basic science in understanding disease processes, understanding early breast cancer, and combining that with our data science group so that we're putting all of this information into the analysis of the patient initially, therefore giving more information than our usual clinical pathologic study or report. So with that, I am very pleased and honored to have provided this opportunity to discuss assays, the genomic ones available now, as well as the future. I thank you so much for your attention, and we will have the opportunity for questions. Thank you so much for inviting me to give this presentation.